fluid, electrolyte, acid-base regulation. Electrolytes are minerals in the body that conduct electrical charges. Common electrolytes include potassium, sodium, calcium, and magnesium. The levels of electrolytes are evaluated by metabolic panels. These can be a basic metabolic panel, a BMP, or a complete metabolic panel, a CMP. Electrolytes are critical to maintain the balance of water to prevent hypovolemia, dehydration, tachycardia, tachypnea, confusion, headache, kidney stones, and other complications. Water loss occurs through excretion of urine from the kidneys, prolonged vomiting, severe diarrhea, profuse sweating, all increase water loss. The body works to maintain homeostasis by keeping water and electrolytes at a consistent level. The level is monitored by determining the serum osmolality of blood. This is measuring the concentration of solutes to water. As the water decreases, the concentration of solutes increases. This leads to an increase in serum osmolality and indicates a decrease in hydration. Water is located within cells and outside of the cells. There are three main fluid compartments. The largest is intracellular space. This holds 67% of the body's water. The other two compartments, known collectively as extracellular space, are interstitial space, which holds 25% of the body's water, and intravascular space, which holds 8% of the body's water. Osmosis is the movement of water across a semi-permeable membrane from an area of higher concentration of water molecules to an area of lower concentration of water molecules. This is fluid shifting into and out of a cell to maintain homeostasis. Serum osmolality rises. The hypothalamus will stimulate posterior pituitary to release antidiuretic hormone, which is ADH or vasopressin. This acts on the nephrons of the kidneys. The collecting ducts of the nephrons respond to the antidiuretic hormone by increasing the reabsorption of water, decreasing the excretion of urine, and increasing fluid volume of the body. Electrolytes and substances that are solutes in a solution move across those membranes through either diffusion or active transport. Diffusion is the movement of solutes, which are electrolytes, from an area of high concentration within a cell to an area of low concentration, which is the intravascular area. This will continue until equal numbers of solutes are inside and outside of the cell. Diffusion is a passive process. It does not require any energy. Active transport uses energy or adenosine triphosphate to move solutes from an area of lower concentration to an area of higher concentration. Nurses need to know the value of the electrolytes. This helps determine the fluid balance. Potassium is the largest intracellular electrolyte. The function of potassium is to support the transmission of electrical impulses of the nerves and muscles. The kidneys are responsible for the primary excretion of potassium, and the rest is lost through sweat in the digestive tract. Hypokalemia, or a low potassium level in the blood, is when the level of potassium falls below 3.5 milliequivalents per liter. Critical values are when the measurement is less than 3 milliequivalents per liter for adults and 2.5 milliequivalents per liter for newborns. The most common cause of hypokalemia is the loss of potassium from the kidneys or the gastrointestinal tract. Potassium wasting diuretics like loop diuretics, thiazide diuretics, or osmotic diuretics are common medications that result in hypokalemia. Mild hypokalemia, which is a range of 3 to 3.5 milliequivalents per liter, may or may not present with any signs. Manifestations of hypokalemia measuring less than 3 milliequivalents per liter will include muscle weakness, cardiac arrhythmias, constipation, and fatigue. Severe life-threatening hypokalemia is a potassium level less than 2.5 milliequivalents per liter. The patient will have respiratory paralysis and respiratory failure. This may include a paralytic ileus, which is an obstruction in the intestine, hypotension, tetany, rhabdomyolysis, which is muscle tissue breakdown, and life-threatening cardiac arrhythmias. Hyperkalemia is the main cause of renal failure. Potassium-sparing diuretics, non-steroidal anti-inflammatory medications or NSAIDs, and angiotensin-converting enzyme inhibitors are medications that result in hyperkalemia. Sodium is the most common extracellular electrolyte. It supports neurologic and neuromuscular function, regulates the body's fluid balance, helps maintain blood pressure. Hyponatremia is a level of sodium that falls below 136 milliequivalents per liter. Critical values are less than 120 milliequivalents per liter. Excess water is the most common cause of hyponatremia. Too much water dilutes the sodium level. Thiazide diuretics, these are medications that most commonly result in hyponatremia. They cause a loss of sodium through urinary loss. Moderate hyponatremia signs and symptoms are lethargy and confusion. It may include a headache, restlessness, and irritability. Hyponatremia becomes more severe. Signs and symptoms of muscle twitching and a further decrease in level of consciousness, seizures, and coma can occur. Hypernatremia. This is a sodium level that is greater than 145 milliequivalents per liter, and critical values are greater than 160 milliequivalents per liter. Hypernatremia is from too little water, too much sodium, or a combination of both. Signs and symptoms are similar to hyponatremia: confusion, lethargy, and irritability. If sodium levels increase in severity, there will be muscle twitching and increased changes in level of consciousness, with seizures and coma that can occur. Calcium is the most abundant mineral with multiple functions. Calcium is found in blood and cells. 99% of calcium is stored in bones and teeth. Calcium assists with mineralization of bone, muscle contraction, nerve transmission, clotting of blood, hormone secretion, and normal functioning of the heart. The range for serum calcium is 9 to 10.5 milligrams per deciliter, and ionized calcium is 4.5 to 5.6 milligrams per deciliter. Hypocalcemia is a serum calcium level below 9 milligrams per deciliter, an ionized level that is less than 4.5 milligrams per deciliter. Critical values less than 6 milligrams per deciliter for serum calcium and 2.2 milligrams per deciliter for ionized calcium. Medications that lead hypocalcemia include stimulant laxatives. These decrease the absorption of calcium. Long-term use of glucocorticoids. These deplete the calcium stores by increasing the risk of developing osteoporosis. And loop diuretics. These lead to an excess calcium excretion by the kidneys. Medications used to decrease gastric acid, proton pump inhibitors, and histamine 2 blockers can lead to hypocalcemia by decreasing the breakdown of fat, which is important for calcium absorption. Another cause of hypocalcemia is the lack of circulating parathyroid hormone. Signs and symptoms will include numbness and tingling of the fingers and toes, around the mouth, muscle cramping and spasms on the back and lower extremities. Two distinct findings will be elicited if hypocalcemia is suspected: Chevet's sign and Trousseau's sign. Hypercalcemia is a serum calcium level greater than 10.5 milligrams per deciliter and an ionized calcium level greater than 5.6 milligrams per deciliter. Critical values are greater than 13 milligrams per deciliter serum calcium and 7 milligrams per deciliter ionized calcium. The most common causes of hypercalcemia are hyperparathyroidism and cancer. Signs and symptoms will include constipation, abdominal pain, nausea and vomiting, and anorexia. These are routinely the first indications that an individual will notice. As calcium levels increase, confusion and behavioral changes will be noted. Thirst will occur, polyuria, bone pain, and muscle weakness will present. Hypercalcemia reaches critical levels. This will cause arrhythmias, delirium, coma, and renal failure. Magnesium is the second most common intracellular electrolyte. The body's store of magnesium, 50 to 60% of it, is located in the bones. Magnesium assists in the regulation of nerve and muscle function, maintaining blood pressure and serum glucose level, support bone and teeth health, and synthesize protein, DNA, and RNA. The reference range for magnesium is 1.3 to 2.1 milliequivalents per liter. Hypomagnesemia are levels below 1.3 milliequivalents. Critical values are less than 0.5 milliequivalents per liter or greater than 3 milliequivalents per liter. Clinical signs routinely do not occur until the level falls below 1.2 milliequivalent per liter. Symptoms will include nausea, vomiting, decreased appetite, fatigue, and weakness. With further decline, signs and symptoms will become more severe and include neuromuscular, which are muscle cramps and spasmicity, numbness and tingling, seizures, tetany, and personality changes. Hypermagnesemia is a greater than level of 2.1 milliequivalents per liter. The common cause is acute or chronic kidney disease. When the levels exceed 7 milligrams per deciliter, moderate signs and symptoms will include increased confusion, sleepiness, blurred vision, and a headache. Decreased reflexes, bladder paralysis, flushings, and constipation may present. Hypermagnesemia levels greater than 12 milligrams per deciliter cause severe reactions, including muscle flaccid paralysis, decreased respiratory rate, hypotension, bradycardia, and dysrhythmias. Magnesium has a long half-life. Therefore, decreasing serum levels will take more than 24 hours. 3 distinct imbalances threaten the body's homeostasis: dehydration, hypovolemia, and hypervolemia. Dehydration is due to a loss of water or lack of water intake without a loss of sodium. Water depletion will cause altered electrolyte water imbalance and hypernatremia and an increased osmolality. Body water shifts from inside of the cell to the extracellular space. This results in cell shrinkage. Signs and symptoms will include an altered cognitive and neuromuscular function related to hypernatremia, which is thirst, lethargy, dry mucosa, and oliguria. The treatment is to restore the water balance to the body and address the cause of water loss. The fluid of choice is dextrose 5% in water, or D5W. This contains no sodium and glucose in the solution, and it is quickly metabolized. Hypovolemia is a loss of both fluid and electrolytes. This leads to a decrease in the circulating blood volume and perfusion to the tissues. This is also known as fluid volume deficit. Signs and symptoms will include thirst, dryness of mucous membranes, decreased skin turgor, decreased urine output. If the loss is not corrected, further signs and symptoms will be lethargy, muscle weakness, and orthostatic hypotension. With severity, tachycardia will occur as the body will attempt to maintain the circulating blood volume and to perfuse the vital organs. If the circulating blood volume loss is greater than 20% of the total volume, hypovolemic shock can occur. The treatment for this will depend on the cause, and it is aimed at controlling the fluid or the blood loss, replacing the components, restoring the circulation in the body. For moderate or severe hypovolemia, the fluid of choice is 0.9% normal saline or Ringer's lactate. Hypervolemia is too much water and sodium in the extracellular space, particularly the interstitial compartment. The goal of the treatment is to manage the cause while decreasing excess fluid. Diuretics are commonly used to increase the urine output and reduce the fluid volume. Limiting fluid and sodium intake and daily weights will be prescribed. Rehydration is restoring the water loss into the body's tissues and fluids. It is important to consider the client's age. Oral rehydration, the client must be capable of ingesting fluids by mouth regardless of age if their renal functioning is adequate. Frequent and small amounts of fluids containing glucose and electrolytes will be provided. For children, So the swallowing ability will be assessed prior to initiating oral rehydration. Small amounts of liquid given that will equal 5 milliliters every 5 to 10 minutes will be increased as tolerated. A syringe will be used to administer the fluids and instilled slowly toward the side of the oral cavity into the cheek to avoid choking or aspiration. Children may receive 50 milliliters per kilogram of fluids over 4 hours for mild dehydration and 100 milliliters per kilogram for moderate dehydration. For older adults, they are encouraged fluid intake to prevent dehydration. They are offered water throughout the day, taking small sips if necessary. They are provided foods with high water content, like watermelon and cucumber. Encouraging more fluids if the individual has diarrhea, vomiting, or if illness is present. When oral rehydration is contraindicated, or if the individual is unable to consume adequate liquids orally, the provider can prescribe rehydration intravenously. Intravenous or IV means within the vein. IV therapy will include initiation, care, and management of vascular access devices with administration of fluids and medications. This is the role of the nurse. To administer IV therapy, IV access must be established. A tourniquet will be used to dilate the veins for visualization and access. The tourniquet will be applied 5 to 10 centimeters above the selected site. When determining the site to initiate IV access, select a vein that feels pliable and smooth. Solutions that are used to treat fluid imbalances include crystalloid solutions and colloid solutions. Crystalloid solutions are fluids that contain solutes. These are electrolytes or dextrose. These are readily dissolved in a solvent, which is water, and diffuse through the cell membrane. These are classified according to their osmolality: hypotonic, isotonic, or hypertonic, as well as tonicity, the ability to make water move in and out of the cell by osmosis. Colloids are solutions that contain large molecules that are unable to pass through the capillary semi-permeable membrane. These are referred to as plasma or volume expanders, and these remain within the circulating volume. These have a higher cost than crystalloids and are used to increase the osmotic pressure with plasma, resulting in fluids drawn into the intravascular space. Fluids that move from an area of lower concentration to an area of higher concentration and increasing blood volume. These fluids would be albumin 5%, albumin 25%, dextran 40, dextran 70, and hetastarch. Hypotonic solutions are solutions having fewer solutes than cell components. This causes fluid moving into the cell. This would be 0.45% sodium chloride. Isotonic solutions are solutions that have the same number of solutes compared to the cell components, causing no fluid movement in or out of the cell. These solutions are 0.9% sodium chloride, lactated ringers, and dextrose 5% and water. Hypertonic solution is a solution having more solutes than are present within the cell, causing fluids to move out of the cell. These solutions are dextrose 10% in water, dextrose 5% in lactated ringers, dextrose 5% in 0.9% sodium chloride, dextrose 5% in 0.45% sodium chloride, and 3% sodium chloride. Tonicity is the solution's ability to make water move in or out of the cells. This includes isotonic, hypotonic, and hypertonic solutions. IV flow rates. The rate of the IV fluid that is infused. This is based on the clinical presentation and the need for replacement fluids. The administration of IV fluids is accomplished by the nurse, who calculates the flow rate, the infusion time, and the total volume based on the provider's prescription. There are various tubing options for IVs, including primary tubing, which is the main tubing set that delivers the IV solutions, and secondary tubing, which administers medications. This tubing attaches to the primary tubing using a needleless adapter or a hub. The standards are that tubing sets are changed every 96 hours or according to facility policy for continuous infusions, and every 24 hours for intermittent infusions. Tubing for lipids is changed every 12 hours and with each new container of lipids. Blood administration tubing sets are changed after every unit or every 4 hours. The body contains approximately 5 liters of blood. The volume of whole blood is divided into two components, cells and liquid or plasma. The cellular portion of blood contains red blood cells, white blood cells, platelets, and this is approximately 40% of the blood volume. The plasma or the liquid is the remaining 60% of the blood volume. Red blood cells, also known as erythrocytes, make up 45% of the cellular portion of whole blood. These red blood cells are made in the red bone marrow that is stimulated by the hormone erythropoietin. This is produced in the kidneys. The lifespan of red blood cells is approximately 120 days. Red blood cells transport oxygen from the lungs to the body tissues. The oxygen binds to the protein hemoglobin contained in the red blood cell. In the tissues, oxygen is exchanged for carbon dioxide and then transported back to the lungs to be exhaled. Red blood cells give blood its distinctive red color. Hematocrit is the percentage of whole blood that is made up of red blood cells. Hemoglobin is the capacity of the red blood cells to carry oxygen. Granulocytes are a component of whole blood obtained through apheresis. These are white blood cells that can be transfused to treat individuals who have neutropenia, or a low white blood cell count, or an infection that is not responding to antibiotics. Platelets, also known as thrombocytes, are fragments of cells contained in whole blood and produced in the bone marrow. Platelets promote the clotting of blood. Plasma is the liquid portion of blood, roughly 55% of whole blood, and it consists of mainly water. It transports the cells and helps maintain blood pressure and blood volume. Blood type is inherited. It's based on the blood types of the parents. There are 4 basic blood types: A, B, AB, and O, and they are identified either by the presence or the absence of an antigen. Remember, an antigen causes an immune response if it is unfamiliar to the body. The Rh factor is a protein that is either represented by a plus sign if it is present in the blood, or a negative sign if it is absent. By adding the Rh factor to the blood type produces 8 distinctive blood types: A positive, A negative, B positive, B negative, AB positive, which is the universal recipient, AB negative, O positive, and O negative, which is the universal blood donor. When administering blood, a nurse must remain with the patient for the first 15 minutes of blood or blood product transfusion. Peripheral IV catheters. These are utilized in extremities for the adult: hand, wrist, forearm, or antecubital fossa. For pediatrics, the veins are used in the scalp or the lower extremities. These catheters are single lumen plastic catheters that are inserted into a peripheral vein. Fluids, medications, and blood products are administered through the peripheral IV directly into the bloodstream for quick absorption. A central venous access device. This is an IV that is placed into a large vein. These are long catheters with the tip placed into the central vein, usually the lower superior vena cava or the inferior vena cava. These are inserted percutaneously or surgically implanted to administer blood products, medications, fluids, and other therapies. Central venous access devices are an option for those individuals that require frequent or long-term IV therapy. To prevent occlusion or clot formation in a central venous device, standard practice includes flushing the device with saline or a low concentration heparin according to the facility policy. There are various IV-related complications. One is phlebitis. This is an inflammation of the inner lining of the vein caused by the cannula movement, inadequate dressing, the speed of fluid infusion, the type of medication infused, the length of therapy, the failure to follow aseptic technique when initiating or managing the site, or through administration of a contaminated solution. Circulatory overload. This is caused by infusion of excessive amounts of crystalloid fluids or blood products, or infusing too quickly. Infiltration or extravasation. Medications or fluids move from vein into surrounding tissue. Infiltration involves non-vesicant, which is non-irritating fluids. Extravasation occurs with inadvertent administration of a vesicant or an irritating fluid into the surrounding tissues. A vesicant is a fluid or a medication that is harmful to the surrounding tissue and capable of causing damage to the tissue or necrosis. An air embolism is an obstruction of a vessel by air. These symptoms are an abrupt onset, difficulty breathing, cough, wheezing, low blood pressure, tachycardia, and chest or shoulder pain. If an air embolism is suspected, the infusion should be stopped immediately and the line clamped. The patient should be positioned with the head down on the left side. The rapid response or the code team should be notified. An infection occurs when aseptic technique is not used. Signs and symptoms are redness, swelling, induration, purulent drainage, pain, and possible fever. Intake and output are the measuring and documenting. Intake is a nursing function. With fluid or electrolyte imbalance, accurate measurement and documentation of intake and output is integral to care. Intake is the amount of fluid taken in and includes anything ingested orally or by IV, through a feeding tube, or during irrigation. Output is the amount excreted. This includes urine, stool, wound or fistula drainage, or emesis. Acid-base balance is maintained by the lungs and the kidneys. The pH of the blood is determined. The scale for pH ranges from 0, which is strongly acidic, to 14, which is strongly alkaline. A 7 is considered neutral. pH concentrations less than 7 are acidic. Concentrations greater than 7 are alkaline. The reference range for the pH of blood is 7.35 to 7.45. Death will occur if the pH is 6.9 or less, or greater than 7.8. The body maintains the blood's pH by the use of buffers, the respiratory and renal regulation, to prevent the blood from becoming too acidic or too alkaline. The lungs utilize carbonic acid. This is created when carbon dioxide mixes with water. This is slightly acidic. The kidneys utilize bicarbonate, HCO3. This is slightly alkaline to maintain the acid-base balance. Imbalances of pH will either lead to acidosis with a pH less than 7.35 or alkalosis with a pH higher than 7.45. Respiratory imbalances occur with changes in ventilation and will reflect the amount of carbon dioxide that is present. When the carbon dioxide combines with water, carbonic acid is formed, making an acidic environment. With hypoventilation, carbon dioxide is retained. More carbon dioxide is converted to carbonic acid, and an increase in acidity will occur. Metabolic imbalances occur with systemic changes. The kidneys filter hydrogen and bicarbonate and excrete them in the urine or reabsorb them into the bloodstream. If bicarbonate is excreted and hydrogen retained, the pH level will decrease, causing metabolic acidosis. If the hydrogen ion is excreted and the bicarbonate is retained, the pH level will increase, causing metabolic alkalosis. When the lungs cannot eliminate adequate carbon dioxide from the body, respiratory acidosis will occur. This is a low pH and an elevated PaCO2. Respiratory alkalosis is a high pH and a decrease in PaCO2. This can be either acute or chronic and is caused by Hyperventilation. Things like pain, anxiety, severe stress, pregnancy, sepsis, infection, trauma, or fever. There is metabolic acidosis and metabolic alkalosis. Metabolic acidosis, the kidneys are not able to rid the body of excess acid. The lungs try to exhale the acid or the carbon dioxide by increasing the respiratory rate and the depth. In metabolic alkalosis, the body is retaining too much HCO3 or bicarbonate. The lungs try to retain acid by decreasing the respiratory rate, while the kidneys decrease the bicarbonate through the excretion into the urine. There is also respiratory acidosis and respiratory alkalosis. Respiratory acidosis, the body is retaining too much carbon dioxide, often due to respiratory depression. The kidneys will increase the amount of bicarbonate or HCO3 in the body while excreting the hydrogen through the urine. In respiratory alkalosis, the carbon dioxide level drops due to too much being exhaled, usually in hyperventilation. The kidneys will excrete bicarbonate through the urine and decrease the amount of new bicarbonate being produced.